Thank you very much. This is going to be a very small part of your practice, I get that. Um, who am I? So I'm Anton. I've actually been a consultant at the Children's for 24 years now. I'm actually an ICU consultant, but also back in 2009 I retrained and I became a palliative care consultant. It's always been a big interest. So I'm now sort of in my twilight years of working, I'm swapping over to do more palliative care. So thank you so much for this opportunity. I've only got 10 minutes, I've got 10 slides, and then hopefully 5 minutes for any questions. I thought I'd just talk about what paediatric palliative care is and a team, give you some resources and documentation, some declarations of interest. I'm vice chair of the APPM, which is the national medical body for paediatric palliative care, and I sit on the advisory committee for Together for Short Lives, which is the charity. Talk about advanced care planning, a few slides on that. We won't touch on respect, and then how you can help us and maybe how we can help you. That works. So children's palliative care is quite different from adults. Often we'll look after these children for many, many years. We have a very holistic approach, and it does cover, you know, all the aspects of medical care. You'd think complex symptom control, bereavement, death, dying, but also the social aspects. And this is, I don't know if you can all see this, this is the sort of parallel planning aspect that we talk about in paediatric palliative care. So often at the diagnosis of a life-limiting condition, or actually at the recognition that a child has a life-limiting condition, hopefully we get a referral at that stage. And our role with that family and patient initially might be just once a year, maybe once every 6 months, but over time it increases, especially if they have a degenerative condition or a slow-growing oncology problem. And then we take over from their primary specialists as they enter the more dying phase, and we take more control. But it's very much a joint care. And although that's a straight line, it's not reflective, because people will dip in and we will be more involved and less involved. So I think that's quite an important concept. So it's very fluid relationships, and it's about this parallel planning, so sort of thinking ahead. I think paediatric palliative care we concentrate a lot of living with a life-limiting illness, and that's what we do with a lot of our advanced care planning, and I'll show you a slide of that in a minute. I think the other thing, we have children who get better. So we had a child recently who had a diagnosis of severe cardiomyopathy, had a full advanced care plan in place, came home from intensive care with a full respect in place. Over a year, he improved, got better. So we've discharged him. So we do discharge children from palliative care. I think the other thing to say is, because I'm an intensive care consultant, I do a lot of compassionate extubations. That's one-way extubations distant from the ICU. 33% of my one-way extubations over the years survive a month. So that's quite an important concept to realise, especially when you're talking to families. So this is a slide which isn't published yet. It's from Together for Short Lives, and their restructure. This is the charity that looks after the whole of paediatric palliative care in the UK, and they're looking at restructure. And it's I won't go over in too much detail, but it's very much what Anne was talking about. So it's about identifying, recognising the children who would benefit from the service. And that's even a big barrier with some of my colleagues. I know the colleagues who will refer patients, and I know the colleagues who won't, for a variety of different reasons. Then we have to assess what are the child's needs, what are the family needs, and how can we help. And then it's about deciding about what stage of their trajectory or journey, especially for the families, we like to call it a journey, at which stage they're at and how we can help, support, intervene, and improve the quality of life. So we're quite a small service. There's myself, who actually for the whole region has 3 days a week, which isn't a lot of time when you think about. I cover Barnsley, Rotherham, Bassett, or Doncaster. I have Gemma, who I'm going to ask to stand up, who's my CNS. So we have one band 7 CNS full time. We have a band 6 CNS. We have a band 4. We have 1 day a week of play specialist and 1 day a week of clinical psychologist for Sheffield. We've recently branched out into the region. I cover the region for specialist services, but we do have half a day a week of a consultant time and 0.6 of a band 6 palliative care nurse in each of the places, which is really useful. So that's the Sheffield team, and as I say, we cover regionally. There is Blueboa Children's Hospice, which is locally out in North Anston. That's going through some structural changes at the minute, but hopefully that's going to come online fully soon as a nurse-led service. That's our email, and I'll put the email up again. We'll take referrals from anyone. So if anyone has a concerning patient or they want to discuss, they just email us and we'll pick it up, and we usually respond within 24, 48 hours. We do a huge amount of training. We run specialist training for the region. We go out once a month to each of the places and we do a half-day training. We run palliative care simulation courses if anyone's interested. A lot of it's actually about conversations, and I think it's very transferable to adult. It's about getting the aspects of palliative care across to families, and he's talking, and the feedback, we run 5 of those a year, and we're willing to put on more if we can. We also do verification training for nursing staff as well, for paediatrics specifically. So these are just some of the resources that you can access, and again the websites will be on the last slide. I'm happy to share the slides. There's Together for Short Lives, which I've talked about, so they have a really good symptom control manual. You can download it on your phone as a PDF. It's about 200 pages, but you just put in the topic you want. It's brilliant. Things like constipation, super. There's the Association of Palliative Care Medicine, which has its own formulary, which was last updated in 2024. Again, brilliant resource we use it all the time for all our drugs, and it's it's highly referenced. And again, you can download either of those things on your phone as a PDF. The APPM also has lots of symptom control advice. And Together for Short Lives, there's the section for families, because it's not just for healthcare professionals, and there's lots of leaflets and stuff you can print off for your patients. So this is advanced care planning. This is the document we use, and again at the end there is a website that you can download these from. We're not expecting you to fill these in, and it's really just to show you. Each of these boxes are expandable. I'm not going to go through all the boxes because I think it's probably, if you've got the time, just download one, look at the titles. And it really is about planning for the future for these families. It's a dynamic process, so often Gemma and the nursing staff will actually, we'll introduce the concept, then they'll go out and have a number of appointments which may take a couple of hours to go through some of the different aspects, and families are at different stages on their journey, and in the initial stage it may be that this is just a hospital passport and has a list of their diagnosis and complexities. And sometimes, you'll know yourselves with some of these children, they'll have 16 different diagnoses, they'll be under 7 different teams. So it's about having all the information in one place, which makes a difference. So we look very much, it's about hoping for the best, but we're planning for the future. We know the future might not be good. And it is about life. It's not, we don't think of these documents as death documents. We don't concentrate necessarily on respect. And you can have the ACP without having, we always do a respect form, but we will stipulate that they are for full resuscitation and they will have a plan in place. So what are the details? Again, it's very much, we look at them as very much a personalised document for the family. So it's about their goals, their values, their priorities in life and death, and we talk about that in detail. We have the full medical and social history, so that the parents don't have to repeat it if they pitch up at the hospital, and that empowers them hugely, especially if they're going abroad, if they're going even to the south coast or northeast to different hospitals. Everyone's involved, so if we have a child, say with severe epilepsy, we'll ask the neurologist to complete that section. So it's not like it's just us doing it, and we will ask the different teams. We always have a lead consultant, which for Sheffield's usually me. For the DGHs, it will be whoever's lead for palliative care. We individualise treatment, so whatever their symptoms are, there will be a full symptom control. Just out of interest, has anyone actually seen one of their patients, one that we've done? They're pretty some of them are really detailed and really valuable. The biggest complaint that parents have is that when they go into ED, they say the doctors don't read them, which is heartbreaking when you think about the time that goes into them. Again, there is specific information about CPR, but we don't necessarily concentrate on that. So that's me, virtually finished. How can you help us? Having a named GP is really useful, someone, a go-to person in a practice. Doing shared visits, that's really important as we come up to transition, because essentially a lot of the time you're going to be lead for them. Sometimes we get asked, well, you know, this child's 5, why do we need a joint visit? Well, I do go away sometimes, and I need a bit of cover, and you know, no one else at the trust will go out into the community. Communication and promotion just for what we do, really, as much as anything else. And a lot of the medication and prescribing, we rely upon you, obviously.